Will get a question on febrile seizures because it's really hard to ignore a seizure. And I'm going to ask you pretty much to ignore a seizure. So febrile seizures usually occur in previously healthy. The kid has to have no congenital problems. They have to be completely previously developmentally healthy, 6 months to 6 years of age. It is generalized, complete, no focal seizures count, generalized, brief, single episode, no recurrence within 24 hours, no evaluation at all. So you got to take your hands away from any choice of any diagnostic testing or therapeutic testing. So if they come in and they give you a completely normal physical exam with a one-time fever spike and a generalized febrile seizure, you're not going to do anything. If the child is less than 12 months of age, with the first one, you should consider an LP, which means they'll never give you an under 12-month-old. They'll give him like an 18-month-old to just get rid of that controversy. If they are 12 to 18 months of age, then that's still the gray zone. Most recent AAP guidelines said under 12 months, so you'll probably get a 19 to 20-month-old that has a first-time febrile seizure, so that you'll pick that you wouldn't do anything. There's no EEG, no CAT scans, no neuroimaging. You don't do anything. There is controversy about whether, treating the fever makes a difference. Most people do it for comfort, but there's no studies that show that if you alternate Tylenol and ibuprofen, you're going to be able to stop the next febrile seizure. In contrast, afebrile seizures, they all get EEGs. If they have a focal seizure, if it's prolonged, or if you see any focal findings in the physical exam they give you, get a CT scan of the kid's head, all right? Treatment is going to be, they've redefined status. So status is now considered to be if it lasts longer than 5 minutes. It used to be 30 minutes. Now it's if it's longer than 5 minutes or anything that's back-to-back episodes is defined as status. You want to use benzodiazepines to start with. Most people have switched to midazolam as first line. So it's going to be midazolam intranasal, or you can use Ativan. Most people don't use the diazepam. It has the highest rate of respiratory depression. Then after the benzo, we go to phosphenotoin, and then phenobarb is going to be the third line choice. So it goes benzos, phosphenotoin, then phenobarb. Cerebral palsy is a non-progressive disorder of movement and posture. So it's non-progressive. There's no change in it. They can have a couple of different kinds, spastic diplegic, quadriplegic, or hemiplegic. And you want to, usually what they're going to ask you is going to be what your approach is going to be, and it's going to be a multidisciplinary approach using the different collaborators with the physical therapy, orthopedics, et cetera, to work together as a team for the individual child, because there's such a wide variety of affects they can show. Autism is very, very common, and it seems to be increasingly diagnosed. I think we used to miss a lot of kids with autism. So it is a chronic, non-progressive disability. They can have impairments in social interaction. And remember I told you the test that we want you to screen them for, so we want to screen these kids early in their lives, because it has been shown that we can affect positively language and communication abnormalities the earlier that we intervene. Asperger's is difficulty forming relationships. Autism is going to be language and communication abnormalities. Treatment is behavioral intervention, sensory integration therapy, speech and language training, and social modeling. Usually these questions are pretty easy, because anytime they give you a suggestion of multidisciplinary and you look down it and it involves like language, speech, those are kind of the resources these kids need to improve their communication and improve their ability to fit into the school systems and function. ADHD, very, very, very common. One of the things that they usually ask about the ADHD is you really need to have 6 or more of the following symptoms of inattention, and they have to be present for at least 6 months. They have to be present in multiple different environments. So mom doesn't get to come in and say, my child has ADHD, and you start treatment. Usually you have to have multiple sources, and it's going to be preferably the school, mother, like somebody else that is, if there's daycare or there's something else involved, multiple different people, so that you can get a better inventory of the symptoms that the child has. Usually they're going to have inattention symptoms that are going to involve difficulty of sustaining attention, often does not follow through on things. The reason they went to the 6 months is, does anybody know of any 2-year-old that wouldn't meet the ADHD criteria? So we've got a developmental progression here, and we don't want to start kids on medication who don't need medication, who developmentally aren't there. So it's really important that we kind of take a little time and get a good assessment on these kids, and that's the biggest thing they usually emphasize. You can also have a hyperactivity, impulsivity with these kind of kids with at least 6 months to a degree that is maladaptive and inconsistent with the developmental level. And that's where a lot of pediatricians have problems with the 3 to 4-year-olds, because boys can be delayed in terms of those things. So usually what they're going to do is give you an older kid that's 7 to 8 years old that's having problems in the school setting, and then they'll give you some list of their criteria, and you match them up for the impulsivity, the inattention, and then make a decision about pharmacologic treatment, which is usually going to be with methylphenidate. One thing to remember is that behavioral modification is considered important no matter if you use the therapy or not. And a lot of people will go to using the behavior modification first, trying that for a period of time before they move on to the medication. Here are some other things that I found as I went through the neurology chapters and books that I want you to just kind of review and remember prior to taking the exam. And these are kind of going to be some things you've got to put together and associate. So if they give you a child with infantile spasms, they will usually give you, to make that diagnosis, an EEG with hips arrhythmia. So if you see, they say the child has abnormal movements, we've got an EEG and it shows hips arrhythmia, that's infantile spasms, treatment is ACTH. It's very specific, very well linked together. So that's going to be what your answer is going to be. Motor tics that are simple and are in the younger kids, going to be hard to do, but you need to ignore them. Usually the kids will outgrow them without doing anything, and the medications can make things worse. So make sure that you kind of think about that if they give you a simple motor tic, and pick the answer that's mostly supportive, monitoring the child for further development. If they give you a kid and they say the kid's on the floor and he places his hands on his legs to get up and he waddles, proximal muscle weakness, right? That's how they do it in pediatrics, is they'll say they have to put their hands on their legs to get up, and they'll give them a waddly gait. And what we're worried about is Duchenne's muscular dystrophy or Becker muscular dystrophy. What you'll do is get a CK level, and that will give you information that will make you more suspicious if it's elevated for Duchenne's muscular dystrophy. Becker's muscular dystrophy, the reason you've not heard of it, is much milder, and so usually you don't have the problems you do with the Duchenne's muscular dystrophy. If you have a child with muscle fasciculations and hypotonia, muscle fasciculations is pathognomonic for spinal muscular atrophy. So if you see those words together, that's what you're going to pick as your answer. And I always have to remind myself, sometimes they throw IQ tests around on these scores, and you're sitting there going, I don't remember. Mental retardation by definition is an IQ less than 70 on one of the standardized tests. If they give you a kid that's constipated, poor feeding, weak suck, and weakness, it's botulism. They'll sometimes give you the unpasteurized honey. They'll give you honey as something that the baby was eating. Sometimes they won't, but that combination of constipation, poor feeding, and weakness is botulism, and we use the baby big to treat it. Cushing's, I'm sure you all know this because this is the same across peds and adults. If they give you someone that has irregular respirations, elevated blood pressure, hypertension, and bradycardia, that's going to be the Cushing's triad, and that indicates herniation. And so you should be very aware of that as a kind of end stage event for CNS disease. ADEM versus MS, these are two type of areas where you can get kind of these non-specific changes. ADEM is usually going to be symptoms very similar, almost identical to multiple sclerosis, except the ADEM happens suddenly. It's like over 3 to 5 days the kids will develop all these symptoms. MS is going to be usually slower, visual, then something here, then something there. When you get an MRI, the MS will have new and old lesions. The ADEM has lesions that are all in the same stage. And so if they give you an MRI with lesions in the same stage and a kid that's having those symptoms, that's going to be for ADEM. Last couple of things I wanted to go through. These are a couple of things that as I went back through, you have to know, but they were newborns, and I felt like the newborn section was already too long, so I kind of put them at the end. just to kind of reinforce a couple things. If you have a newborn that shows up, like you have a kid show up at 2 to 3 weeks of age that's went home and is feeding, and they show up with vomiting, tachypnea, apnea, some of the kids will be a little older and they're starting to show developmental delay, and they give you an elevated ammonia, it is a urea cycle defect. So anytime you see an elevated ammonia level on your testing, it's going to be urea cycle. Give them glucose and cut off any protein. So that's what you should do to treat them. They'll usually ask the question in that way. Or they'll ask, what's the most common thing that you'll see with the urea cycle defect? And it's going to be an elevated ammonia. Hypocalcemia is going to be something you need to worry about. That's why I told you exclusively breastfed infants. If they give you an exclusively breastfed infant that's on no vitamin supplementation, who comes in with an x-ray that is characteristic with the rickets, with the bowing of the femurs or the bowing of the tibias, then they will also usually have a hypocalcemia, hypophosphatemia. You need to start the vitamin D. That's why we start that when the kids are exclusively breastfed, start them on vitamin D supplementation to prevent rickets. Galactosemia, I'm going to mention it again because they really liked it. Vomiting, lethargy after breast milk or formula. These are kids that have not gotten a state screen back or were born at home, didn't get a state screen. They have a low blood sugar. They've got cataracts on exam, or they come in with E. coli sepsis. It's galactosemia. And that's what you should suspect and go ahead and order the test for that.